Hello friends, now we discuss mood disorders. As you know, mood and affect, these two terms are used interchangeably. So affective disorder or mood disorders, many times you will find they are used interchangeably. Mood may be happy or may be sad. So we start with sadness of mood, that is depression, excessive sadness in layman language we say, but depression is a common term regularly used. We found that another name of depression or psychiatric term of depression is major depressive disorder. Nothing major about it, but the name is major depressive disorder. Another name is unipolar depression. Yes, you will remember these three names, very important. What are the symptoms of depression? We found that patient is having low energy, sadness of mood, low energy, sadness of mood. Sadness should be persistent and pervasive. Persistent means every time patient is sad. Pervasive means all aspect of life patient is sad. Patient is talking to somebody, he is sad. He is playing, he is sad. He is playing cricket, he is sad. He is eating, he is sad. He is talking to his girlfriend, he is happy. It's not depression, because to say depression, mood should be persistent and pervasive. All aspects should be affected. Okay. Question has been asked on this pervasive word. Decrease interest, and there is anhedonia. You all know, loss of pleasure in previously pleasurable activity. Anhedonia is also included in negative symptoms of schizophrenia. We have discussed it. So mnemonic is EMI. 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 Now other symptoms: guilt, worthlessness, decreased appetite, decreased psychomotor activity, decreased sleep. Usually sleep is decreased, appetite is decreased. If appetite is decreased, there is loss of weight, loss of weight. So mnemonic is GAPS, 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 again S, cause depression. So complete mnemonic is EMI, GAPS, cause depression. If you will not be able to pay EMI, gaps are there, you definitely it will cause depression. C for concentration, decrease concentration. Yes, decrease concentration. It may lead to forgetfulness. There may be suicidal thoughts. Point it out. In any question, if you find that depressive symptoms are there and suicidal thoughts are there, yes, I highlight this, and without second thought, you will mark the answer that this is severe depression. This is severe depression. If suicidal tendency is there, yes, question has been asked, they asked different symptoms, and they gave suicidal risk is there. Diagnosis is moderate depression, mild depression, severe depression. Without second thought, severe depression would be there. Sleep is decreased, there is early morning awakening. Early morning awakening means patient wake up early in the morning. Suppose normally he wakes up at 7 a.m. Now he will start waking up at 5 a.m. 2 hours prior to normal awakening time. That is early morning awakening. Or terminal insomnia. Terminal insomnia. Appetite is usually decreased, so weight loss. 5% weight loss in a month. In a month is significant. Point it out. This question has been asked. In tuberculosis, the significant weight loss is 10%. But in psychiatric disorder, just like depression, or in depression, better to say, in depression, the significant weight loss is 5% in a month. Okay, so mnemonic we do remember. All symptoms you can remember. According to DSM-5, DSM-5 said that out of these symptoms, if 5 symptoms are there, yes, for 2 weeks, I will make the diagnosis of major depressive disorder or depression or unipolar depression. Although, to be more precise, out of five symptoms, one symptom should be either mood or interest. Okay. recently asked question in FMG that they ask that the main feature or key feature of depression is, you all know depression is mood disorder. So key feature, if you ask me, I will say this is mood. This is the key feature of depression. Yes. Now, five symptoms out of these, if five symptoms are present for 2 weeks, major depressive disorder or unipolar depression or depression. And we found sometimes these patients may have psychotic symptom, just like delusion. Suppose this patient is having five symptoms out of these for 2 weeks, and patient is also having delusion of nihilism. मान लेते हैं, we take, suppose this patient is also having delusion of nihilism or simply delusion. Delusion is a psychotic symptom. You will say this patient is having depression with a psychotic symptom. Depression with psychotic symptom. Depression with psychotic symptom. Okay? Or psychotic depression. Or psychotic depression. What is the treatment of psychotic depression? Point it out. In this, depression is there. In psychotic depression, depression is there. So if you want to treat the depression, definitely you will treat by antidepressant. Antidepressant treatment. If you want to treat psychotic symptom, you will give antipsychotic. Antipsychotic. So antidepressant plus antipsychotic, the treatment of psychotic depression. To treat the depression, yes, antidepressant. To treat the psychotic symptoms, antipsychotic. And if patient is not improving, if patient is not improving, then you will current लगा दो, नहीं ठीक हो रहा current लगा दो. You will give modified ECT. You will give current. Yes, if patient of psychotic depression, yes, not improving by this medication, that is an indication of a modified ECT. In the same way, if severe depression, suicidal thoughts are there, in complete psychiatry, wherever you find the word suicide, this is indication of modified ECT. Yes, in depression, if suicide is there, you will think of treatment with modified ECT. So now you know the diagnostic criteria and different questions which has been asked on depression. Now we come to recurrent depressive disorder. Suppose a patient came to you having depressive symptoms and depression criteria is fulfilled, we represent like this. Suppose a patient is having five symptoms for 2 weeks, depression criteria is fulfilled, you will say this is depression. You took past history. What I said, past history is very important, not only in psychiatry, in other branches also, but in this it is important. Suppose you took past history, you found that patient was having previous episode of depression, means previous episode of depression is there. So we will say it is more than one episode of depression, and we will make the diagnosis recurrent depressive disorder. Recurrent, again and again depression is occurring, more than one episode of depression, that is called recurrent depressive disorder. So first episode of depression, this is major depressive disorder or depression, major depressive disorder or depression or unipolar depression. Unipolar depression, I am repeating it again and again. The purpose you will understand shortly. Now at this point, yes, we will not make the diagnosis of depression. At this point, I would say that this is again depression, but the diagnosis, this is episode of depression, definitely. This is episode of depression, current episode is depression, and the diagnosis is recurrent depressive disorder, means more than one episode of depression. Now, I took history in detail and I found that every time this depression occur in winter. Winter means this depression is occurring in a particular season, and you know depression is a mood disorder, depression is affective disorder. So we said if depression is occurring in a particular season, affective disorder occurring in a particular season, seasonal affective disorder, seasonal affective disorder. And the cause of this seasonal affective disorder is winter, change in the circadian rhythm. You know that there would be a long night in winters. Sunlight would be less. रातां लंबिया लंबिया. जब रातां लंबिया लंबिया होती हैं तो कई बार डिप्रेशन हो जाता है. Yes, so seasonal affective disorder, this is occurring in a particular season, winter, but we took history nicely and we found that depression is occurring every time in winter, but we found that in winter there is a closure of a factory in which this patient is working. So every time this depression occur due to, yes, loss of job in winter. Not the winter is not the cause. The cause is loss of job because factory remains closed. Yes, during this period. So the answer would become recurrent depressive disorder if yes, due to loss of job. So this is important and nice question. If they ask that depression is occurring again and again and they give that this is due to winter, that is seasonal affective disorder, but this in winter every time occur due to loss of job, then it would become recurrent depressive disorder. Now, persistent mood disorder, even if you don't remember this name, it's okay, but dysthymia you will remember. Suppose this patient is having depression. I have deliberately removed the criteria of ICD 11, how we make the diagnosis of depression in ICD 11. Yes, but if DSM 5 is, I found most of time it is sufficient. Okay. Dysthymia, yes, dysthymia, patient is having depressive symptoms are there. Suppose 3 symptoms are there, 4 symptoms are there. You know that if you want to make the diagnosis of depression, at least 5 symptoms should be there for 2 weeks. But suppose this patient is having only 3 symptoms, 2 symptoms are there, means diagnostic criteria of depression is not fulfilled, and these symptoms continue for 2 years. If these symptoms continue for 2 years, never fulfill the criteria of depression, subsyndromic symptoms of depression means criteria not fulfilled. Criteria not fulfilled. This is dysthymia. Suppose a patient came to you having symptoms of depression, all the symptoms of depression are there, 3 4 symptoms are there, better to say 3 4 symptoms are there, yes, 3 4 symptoms. Again, diagnostic criteria not fulfilled. Diagnostic criteria not fulfilled for 2 years. What would be the diagnosis? Yes, you will say dysthymia. Same thing I told you. Yes. But now I am extending. This patient, when you made the diagnosis of dysthymia, after the making of diagnosis of dysthymia, this patient presented with few more symptoms. Now at this point, patient is having all 5 symptoms. All 5 symptom diagnostic criteria of depression is fulfilled. You will say this is depression. You will say patient is having depression. Patient would say, Doctor Saab, what are you doing? Sometimes you say dysthymia, sometimes you say depression. What are you doing? You will say you have 2 types of depression. Previously you were having dysthymia. Now you are having depression. Means 2 type, double depression. Double depression means question was asked. Double depression is depression in dysthymic patient. Dysthymic patient. This question has been asked. Now we come to adjustment disorder. What is adjustment disorder? Adjustment disorder usually occur after subjective stressor. Subjective stressor means the effect of stressor depends on the subject. I take one example of subjective stressor as relationship problem, divorce. After divorce, a lady is very sad. Yes, 29-year-old lady was divorced by her husband. After that, she remained very sad, unable to sleep, don't take food. But another lady is very happy by saying that now he is saved, I am saved. I was so tired of this bad person. I wanted to kill him. I recently saw Crime Patrol and idea came in my mind and I bought a new knife. But he divorced, he is saved, I am saved. Both are happy. And this is extreme just to put humor, otherwise means in subjective stressor, the response will depend on the subject. Few person would be little sad, less sad, few person would be more sad. Okay, means depending on the subject. In the same way, financial problem, breakup, breakup, this is relationship problem, medical illness, they are subjective stressor. As I told you in this question, after breakup or divorce, 29-year-old lady, now she is having sadness of mood, unable to sleep, don't take food. These symptoms are also present in depression. So after these subjective stressor, patient may present with depressive symptom, or patient may present with anxiety symptom. But these symptoms never fulfill the criteria of either depression or anxiety disorder. Means symptoms are there, but not fulfill the criteria, not fulfill the criteria of depression or anxiety disorder. If they don't fulfill the criteria, then diagnosis is adjustment disorder. Okay, so in this lady is having 3 symptoms of depression, but you know that if you want to make the diagnosis of depression, there should be at least how many symptoms? 5 symptoms should be there. But this is having only 3 symptoms, diagnostic criteria of depression not fulfilled, the diagnosis is adjustment disorder. But in the same question, if this lady is also having decreased interest, decreased psychomotor activity, 5 symptoms are there, criteria of depression is fulfilled, criteria fulfilled, yes, criteria fulfilled, the diagnosis would become depression. Okay, means adjustment disorder is diagnosis of exclusion. If symptoms are there but don't fulfill the criteria of other disorder, you will say that a patient is having adjustment disorder. Got the point? So same question, if few symptoms are changed, then the answer would be changed. Got the point? Now, treatment, supportive psychotherapy. Why we said we defined this? Because if patient is having adjustment disorder, we will give psychotherapy. You must have heard that song, Dil pe patthar rakh ke maine breakup kar liya. That girl was very happy, and there was a boy in that song who used to say, yes, don't worry, ab acha hua, now you are open, you can make a new relation, like that. He was giving her psychotherapy. This psychotherapy is sufficient. We don't give that type of psychotherapy, but psychotherapy is sufficient to treat these symptoms. But if symptoms are so severe that diagnostic criteria of depression is fulfilled, we should give treatment on the guidelines of depression. This is the reason we made the diagnosis in this way. If patient depressive criteria fulfilled, depression, will give antidepressant or whatever the treatment criteria are there, I will discuss shortly. Or if diagnostic criteria are not fulfilled, then you will give supportive psychotherapy. Now, I will make a flow chart. It will help you to remember. Very, very important topic. If a patient came to me having these 5 symptoms, 5 symptoms are there for 2 weeks, you will say the patient is having major depressive disorder or depression. In this patient, suppose these symptoms are there, these 5 symptoms are there, 2, 3, 4, 5 for 2 weeks, and patient is also having, yes, psychotic symptom. Suppose hallucination. You will say the patient is having depression with psychotic symptom, or psychotic depression, sorry. Yeah, now you can, depression with psychotic symptom or psychotic depression. And you know the treatment in antidepressant and antipsychotic treatment. I write here antidepressant plus antipsychotic. If not improve, then modified ECT, you all know. Okay. Now, if the same patient comes to you with these symptoms and you took history, that patient was having similar episode 1 year back, you will say more than one episode, that is a recurrent depressive disorder. You took history properly and you found that every time depression occur in winters, you will say this is seasonal affective disorder, seasonal affective disorder. Got the point? Now, if these four symptoms are there for 2 years, 2 years, you know, diagnostic criteria of depression not fulfilled, only four symptoms are there, three symptoms are there for 2 years, you will make the diagnosis of dysthymia. You will make the diagnosis of, yes, dysthymia. Now, after that, patient developed few more symptoms, suppose decrease interest, means now dysthymia plus more symptoms, now diagnostic criteria is fulfilled. Now you will say this is double depression. Are you getting these points? Now, why I'm telling you, because questions are asked every time, you will find that symptoms are same but the answer is different. So it is must know topic every time one question, and many times I have seen students that they mark wrong answer because they just remember depressive symptoms are there, this should be the diagnosis. No, very precisely you should know. If these four symptoms are there, I take different color. These four symptoms are there after breakup. These four symptoms after breakup. Means depressive criteria not fulfilled. Depressive criteria not fulfilled, diagnosis would be adjustment disorder. Yes. Now the same patient, all these five symptoms are there. I make oval like this. All these five symptoms are there after breakup. Means depressive criteria is fulfilled. Please do comment if you know, think in your mind. Yes, what is the diagnosis? Major depressive disorder. If after breakup diagnostic criteria of depression fulfilled, then depression. If diagnostic criteria not fulfilled, then adjustment disorder. This flow chart will help you to solve multiple questions. Now, I solve one question. A 40-year-old woman was divorced by her husband 3 weeks ago. Patient presented in psychiatry OPD with her brother. Yes, so duration of symptoms more than 2 weeks. Divorce means stressor is there. Subjective stressor is there. She appears sad. Sadness, first symptom. First symptom is sadness. She does not show interest in activities in with her family which she used to enjoy. Yes, not enjoying which she used to enjoy. Anhedonia. Anhedonia. Not getting pleasure in previously pleasurable activity. Anhedonia. Yes, second symptom. She report difficulty in concentration at summer job. Third symptom, sleep appetite and energy are decreased. The sleep fourth symptom, appetite fifth symptom, energy sixth symptom, five more than five symptom, five or more than five symptom, more than 2 week, depressive criteria fulfilled. In spite that subjective stressor is there, we will not say this is adjustment disorder. This is depression. This is major depressive disorder. This is major depressive disorder. In this patient, all the criteria of depression fulfilled after the subjective stressor, major depressive disorder. In this question, if I change only one word, the answer would be changed. Look at the screen. Yes, if I change only one word, if I change this energy are normal, means this sleep is normal, appetite is normal, energy is normal, means only three symptoms are left. Only three symptoms are left. This after stressor. Yes, three symptoms are there not fulfilling the criteria of depression. Then diagnosis would become option E. I write here. Yes, option E. I write adjustment disorder. Got the point? Now in the same question, if I remove this, all these things, and I say that these symptoms, yes, I remove this, yes, these symptoms are present for 2 years. This is normal. That this is normal means sleep is normal, appetite is normal, energy is normal. Yes, these three symptoms are still present. Sadness is there, anhedonia is there, concentration is there. Three symptoms for 2 years not fulfilling the criteria of depression. The answer would be yes, dysthymia. Dysthymia. Got the point? So a little change can change the answer. Suppose in the same question, I don't change anything. Same question, if I add only one thing, patient also hear voices. Nobody, no other person here. No other person here. Means hallucination is present. The diagnosis would become depression with psychotic symptoms, psychotic depression. Psychotic depression. What about other option? We will take care in later part of discussion. Okay, but or you can say it's not so important. But whatever I have told you here, each and every point is important, which has been asked. Now, in the same question, if you want to add me something more, yes, I say that this patient has previous history of similar episode 2 year back. Means more than one episode of depression is recurrent depressive disorder. Yes, recurrent depressive disorder. Diagnosis would change like this. Okay. Now, signs of depression. Varagut fold, Otto Varagut described this. This is triangular fold at the nasal side of upper eyelid. This is important point, nasal side of upper eyelid, triangular fold. Okay. So this is controversial. At few places it is written that it is on this side, temporal side. No. That is the reason I have kept this synopsis. Otto Varagut described a peculiar triangular shaped fold in nasal corner of upper eyelid. I have taken this paragraph from synopsis. So you can easily go, this is nasal side of upper eyelid. Got the point? It is triangular fold. It is a sign of depression. We found omega sign is present over forehead. Yes, omega shape fold over forehead. So these are signs of depression. They are not diagnostic. They have historical importance. Means you can't make diagnosis of depression on the basis of Varagut fold. It's not for diagnosis. Yes, previously it was very common because antidepressants were not there due to this abnormal sadness of mood, facial expression. These muscles acquire abnormal muscle tone. That's why these folds develop. Okay. This is the signs of depression. Now, etiology of depression, one hypothesis is neurotransmitter hypothesis. We found that decreased serotonin, decreased norepinephrine, decreased dopamine. You will remember the sequence. Yes, most important is serotonin, then norepinephrine, then dopamine. So if question is asked that which neurotransmitter is decreased in depression, best answer would be serotonin. If not given, the answer would be norepinephrine. If not given, the answer would be decreased dopamine. Yes, a question has been asked. In depression, there is decrease. Option A, decrease serotonin and decrease norepinephrine. Option B, decrease serotonin and decrease dopamine. So answer is option A. Okay, you will remember the sequence. Now, other causes of depression. Yes, we found that depression is common in hypothyroidism, hyperthyroidism, okay, diabetes, stroke. Question has been asked. Few drugs may cause depression. Mnemonic is boss interfere. If your boss is interfering in each and every aspect of your work, definitely you will go in depression. B for beta blocker, O for OCP. In all contraceptive pill. Estrogen and progesterone both are there. Which is more important to cause depression? P for progesterone is more associated than estrogen. You remember? Yes, like this. Steroid can lead to depression. Interferon, yes, also lead to depression. Question has been asked. One more question, that we found that 50% of patient of depression have increased cortisol level. So cortisol is also associated with depression. Now, cognitive theory, psychological theory given by Aaron Beck. According to this theory, there is a triad of hopelessness, helplessness, worthlessness. In this, patient sometimes feel that I am worthless. Yes, negative view of self. I am worthless, negative view of self. Helplessness, there is nobody to help me, means negative view of others. Hopelessness, there is no hope for future. दिल ही टूट गया तो जी के क्या करेंगे. Yes, negative view of future. And if hopelessness is there, there is increased risk of suicide. Risk of suicide. So sometimes clinical question is asked, they will give you depressive symptoms and they will give hopelessness is there. So there is increased risk of suicide. You may consider admission of this patient, because if suicidal ideation is there or risk is there, we do admit the patient and high risk management is done, and treatment of whenever suicidal risk is there, we can think of modified ACT. Now, treatment of depression, if mild depression is there, then you will treat the patient by cognitive behavior therapy plus exercise. Yes, this is important. Cognitive behavior therapy plus exercise plus active monitoring. Active monitoring. Why active monitoring? Because you are not giving any drug. So sometimes these symptoms may worsen, and if suicidal ideation comes, that patient may also commit suicide, means you will monitor actively. Moderate and severe depression, you will treat the patient with antidepressant plus CBT. Most common antidepressant used is SSRI, selective serotonin reuptake inhibitor. Yes, why we are using most commonly SSRI? Because it is having least side effect profile. Before going to SSRI, I must tell you that in pregnant women, if mild depression, what is the management? If question is asked in this way, pregnancy, we usually avoid drugs. And if mild depression is there, definitely in mild depression, in normal person also CBT. Okay, normal condition also CBT, but pregnancy, yes, we avoid medication. So definitely CBT would be the answer. SSRI, risk of the following is increased. We found that pregnant women on SSRI, low APGAR score chances are there, ADHD chances are there, delayed motor developments are there, persistent pulmonary hypertension, all these are risk. So answer is ABCD. Just mug it up. Antidepressant, you all know different types of antidepressant. These are SSRI, SNRI, NDRI. Yes, selective serotonin reuptake inhibitor, serotonin norepinephrine reuptake inhibitor, norepinephrine dopamine reuptake inhibitor, tricyclic antidepressant, atypical antidepressant, more inhibitors are there. Now this table will help you to solve multiple question, clinical question. They can give you different scenario and may try to confuse you. So mild depression, I told you CBT plus exercise plus active monitoring. Okay, moderate to severe depression, you will treat with CBT plus antidepressant. Depression with psychotic symptom, whenever you find depression with psychotic symptom, you will treat by antidepressant plus antipsychotic. If not improving, modified ECT. Depression with suicide, I told you, wherever you find the word suicide, yes, modified ECT. Pregnant female having depression and suicidal ideation are there. Yes, would you give ECT? Yes, pregnancy ECT is very safe. Modified ECT. In fact, you can give modified ECT in all trimester, any trimester. All trimesters are safe for ECT. So in pregnancy, suicidal ideation, depression, modified ECT. Treatment resistant depression. In treatment resistant depression, what we do, we may try augmentation. augmentation with antipsychotics means we add small dose of other drug just like antipsychotic with antidepressant, and we found these patient improves. So augmentation, antipsychotic, thyroid hormone. In antipsychotic risperidone, question has been asked, risperidone, we found that this is also used as augmenting agent in obsessive compulsive disorder. This is also used in this. So they ask what are the use of risperidone, the augmenting agent in OCD, augmenting agent in depression, treatment resistant depression. Yes, you can use. If patient is not improving in treatment resistant depression, then you can think of yes, modified ECT. You also think of vagus nerve stimulation. Before that, you want to write RTMS, recurrent transcranial magnetic stimulation. So I can make the sequence 1, 2, 3, 4. Although it's not exact situation sequence, you can't determine that on the basis of these theoretical thing, but you may remember like this. Yes, these are the treatment modalities. Antidepressants are chosen on the basis of side effect profile. Yes, this was the old concept. New concept is antidepressants are chosen partly. This is 11th edition. They have said that determined by side effect profile. But latest edition said that yes, choice of antidepressant partly depends on side effect profile. So this is update. Question has been asked previously. If this question is asked, please do consider this update. Okay. SSRI, common example, escitalopram, sertraline, paroxetine, fluoxetine. Side effect questions are asked. Common side effect, nausea, GI side effect, vomiting, diarrhea. But paroxetine cause constipation. Paroxetine cause constipation because it is having anticholinergic side effect. Anticholinergic side effect. Sexual dysfunction. Yes, SSRI are notorious to cause sexual dysfunction. This is delayed ejaculation. Delayed ejaculation. Decrease libido also. Decrease libido. Decrease or erectile dysfunction. Although most common and important side effect is delayed ejaculation, and we use this property of SSRI or side effect of SSRI in treatment of premature ejaculation. Treatment of premature ejaculation. If a patient is having premature ejaculation, I will give SSRI, paroxetine, and you will find that ejaculation time can be increased up to 8 times. So this is treatment of premature ejaculation. But with that, it is also causing erectile dysfunction. Suppose a patient came to me with premature ejaculation, I gave SSRI, now he is having erectile dysfunction. So it's treatment of sexual disorder is not so easy. But anyways, so whenever you find a question in which they give the history of sexual dysfunction is there, you will avoid SSRI. You will never mark answer SSRI. Whenever history of sexual dysfunction, yes, we want to give antidepressant without sexual side effect. So antidepressant without sexual side effect. Question has been asked multiple times. Bupropion and mirtazapine. Yes. Question, recently asked question in INICET, agomelatine. Not asked till now, but can be asked. No sexual side effect. Antidepressant. What is paradoxical suicide? We know in severe depression, patient may have suicidal ideation, but we found that suicide is more common in recovery phase. Yes, we found that in severe depression, patient is having decreased energy, suicidal thoughts. Patient wants to commit suicide, but energy is less. He would say, who will go to the market? Who will buy rope? Who will hang himself? Yes, will not commit suicide. looking at the suicidal risk, you admitted the patient, you started treatment. When you started treatment, patient is improving. When patient is improving, we found that this energy improved little bit earlier than the suicidal thought. Means now energy is improving. But suicidal thoughts still present. It is very difficult to change the thought. So it takes time. So suicidal thought is still present. Now, after some time, after 1 month, patient asks, "No, Doctor Saab, I'm very happy. I'm okay. Let me go to home." You thought that he is improving. Definitely symptoms are improving. I should discharge? No. Before discharge, you will do suicide risk assessment. Sometimes what happen, patient is having still suicidal thought, but energy is improved. Now, if you discharge, will go to the market, will buy the rope, will hang himself. Suicide. So suicide is more common in recovery phase. This question is asked. Yes, and most common method is hanging. This is controversial. In medicine, they say that it is poisoning, but in psychiatry, we say it is hanging. Okay, but yes, hanging usually lead to death and they don't reach to the hospital. Reason may be different, but according to me, it is hanging. Okay. Which of the following best describe paradoxical suicide? Suicide occurring at the time when patient starts to recover. These are recently asked question. Yes. Now, a patient was treated with tricyclic antidepressant for severe depression episode in hospital for 4 weeks. Which of the following is most important concern while considering his discharge? You know that whenever we want to discharge, we always assess suicidal risk. We are concerned with suicide risk answer. But this is little bit confusing question because they give tricyclic antidepressant. So whenever we prescribe tricyclic antidepressant, we do monitoring by ECG. Yes, ECG monitoring is required to assess the toxicity of tricyclic antidepressant. In fact, if you ask me, yes, which is the best indicator for toxicity, it is the tricyclic antidepressant level or ECG. So ECG is best predictor of toxicity rather than level of tricyclic antidepressant. 1 point question. Second, yes, when we start tricyclic antidepressant, before that we do ECG. After 7 days, we do ECG. And whenever we increase the dose, at that time we do ECG. So means when patient is being discharged, we are not increasing the dose. When we are not increasing the dose, there is no need to do ECG monitoring. You all know we discharge the patient on the dose which is being given in the ward. We will not change the dose at the time of discharge. At least we will not increase. Okay, definitely. So answer is suicide risk. Now, a patient presented with TCA toxicity, ECG show brood QRS. If more than 100 millisecond, immediately think of sodium bicarbonate antidote. Yes, sodium bicarbonate antidote, IV sodium bicarbonate. If you want to be precise, IV sodium bicarbonate. BPAD, bipolar affective disorder. BPAD means both poles are affected. Happy pole and sad pole means patient is having both depression and mania. I simplify. Suppose a patient came to you having depression. All the criteria of depression fulfilled, you will say this is a depression or unipolar depression. Unipolar depression. I told you the depression, another name is unipolar depression or another name is major depressive disorder. Now this patient came to you again having depressive symptoms, criteria of depression fulfilled, you will say this is a recurrent depressive disorder. You all know. Till now we have discussed. Now this patient is treated completely okay. After some time, few months, few years, he developed hypomania. What is hypomania? I will discuss shortly. For the time being, this is hypomania. Now I would say this is BPAD 2. 2 looks like H. 2 looks like H. BPAD 2. Okay. Now patient is treated and now he recovered completely. Now after some time, patient developed, yes, mania. Mania. So this is mania. Now I would say this is BPAD 1. So mnemonic, wherever you find mania, yes, wherever you will find mania, yes, that is BPAD1 or classical BPAD. Mnemonic or concept, whatever you say, yes, mug up. Mania means BPAD1. In this patient, history of hypomania is there, history of mania is there, means mania is also there, but we will give preference to mania. Once BPAD1, always BPAD1. So if BPAD2, when BPAD2? When hypomania. But if mania and hypomania both are there, preference will be given to mania BPAD1. Now, this patient recovered. Now, this patient developed depression. You will say that this is BPAD1, current episode depression. Current episode depression. We started saying that such a difficult long term, better to say it bipolar depression. Bipolar depression. Now you know the difference. Yes, this was unipolar depression in which there is no previous history of mania or hypomania. In bipolar depression, there is a previous history of hypomania or mania. Bipolar depression. Why we are discussing it in so much detail? Questions are asked. Let me tell you before that. Yes, this is bipolar depression. This is BPAD1, this is BPAD2, and now you know the concept. What is BPAD1, what is BPAD2. I am not concerned about the number of episode. If one hypomania, yes, BPAD2. If one mania, BPAD1. If multiple manic episode, BPAD1. If multiple hypomanic episode, one manic episode, BPAD1. So let me explain this way. Suppose a patient came to you, depression, hypomania, 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 mania. Yes, mania means BPAD1. If a patient came to you, yes, depression, mania, 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 mania. Yes, this is BPAD1. If a patient comes to you, depression, 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 recurrent depressive disorder. Depression is occurring again and again, recurrent depressive disorder. In the same, okay, in a patient, you find, yes, mania, 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 yes, mania, mania, yes, depression, 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 recurrent depressive disorder, mania, 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 recurrent manic disorder. No such terminology. I told you, if mania, BPAD1. Okay, so these question, graph based question, can be asked because they are asking question on BPAD1 or BPAD2. Why they are asking? Because ICD 11 classified BPAD into BPAD1 and BPAD2. This was not present in ICD 10, ICD 11 classified BPAD1 and BPAD2. Potential question. Okay, so I just told you that this is unipolar depression and this is bipolar depression. Why we separated these two terminology? Because in unipolar depression, the treatment is antidepressant. We all know antidepressant we will give depending on the type of depression. Yes, antidepressant is a part of treatment, but we never give antidepressant alone. In bipolar depression, never give antidepressant alone. Why? If you will give antidepressant, there are chances that this patient may go into mania. We have seen few patients of bipolar depression who were in depression. You started antidepressant. Patient came after few days. Now he is very happy. He is in mania, distributing notes. Yes, dancing, singing. That is switching. Switching. Okay. So this is switching. So what is the treatment of bipolar depression? I write here bipolar depression. Bipolar depression. Best drug is olanzapine plus fluoxetine. Fluoxetine. But Question was asked, if a patient of bipolar depression came and you gave antidepressant alone and switched to mania, it switched to mania, what you will do? You will stop antidepressant. Switching, you will stop antidepressant and give mood stabilizer. Mood stabilizer. Question has been asked. Got the point? A recently asked question in INICET about the prevalence of BPAD1. So 1. Yes, BPAD1 lifetime prevalence, 1%, 1. Okay, 1%. Male female ratio, yes, 1%. Suicide rate, 10%. Actually 5 to 15%. Okay. And the age, common age of BPAD1 is around 18 years. Just like schizophrenia, adolescent and young adult. In BPAD2, you will remember 2, if I write 2, looks like F if I rotate. So BPAD2 is more common in female than male. And yes, common age is around 25 years. Mid 20, 25 years. So BPAD2. So this question has been asked recently in INI, means they ask on the prevalence, and this is definitely update. This question has been asked, so this part you can't skip. Now we come to manic episode. In BPAD, manic episode, suppose I said this is mania. If I said this is mania, how we make the diagnosis of mania? In mania, patient is having typical symptom. You have seen a patient. If you have seen, you will never forget, a patient entered the OPD. Suppose I take example, a patient entered the OPD. He says, "Hello doctor, how are you?" Shake hand. Yes, over familiarity. Yes, over talkativeness. Now he is roaming around in the OPD. Doctor Saab, where are you sitting? Such a bad environment, such a bad small OPD. I will make hospital for you. Over talkativeness, over activity. He is roaming around. Yes, and grandiosity. Yes, grandiosity. Increased self-esteem. Yes, psychomotor activity is increased. Increased self-esteem. Grandiosity is there. Over familiarity is there. Over familiarity. Overactivity is there, over sexuality may be there, decrease need of sleep, patient would not sleep the whole night. In the daytime he would say, "Doctor Saab, I am very very energetic," and he will feel him energetic. Yes, decrease sleep and decrease need of sleep is important, because in depression patient would not be able to sleep in the night. In the daytime he would feel tired. Decrease sleep. But in mania, patient is not sleeping the whole night but energetic, means decreased need of sleep. Over talkativeness, yes, they may have flight of idea or prolixity. Prolixity is milder form of flight of idea seen in hypomania. Okay. Distractibility means he will start a work but will not complete the work. Suppose common complaint that he will wake up in the night, he will start washing clothes but will not complete the clothes, and he will jump to another work. Means don't complete the work. Distractibility. Mood may be happy, then you say it is euphoric mania. If mood is irritable, you say irritable mania. Okay, euphoric or irritable mania. So these are the symptoms for mania or hypomania. In mania or hypomania, same symptoms are there. I am avoiding to make mnemonic. Yes, sometimes we say manic person dig fast. Manic person, dig, dig, fast. But if you remember the typical symptoms, you will be able to solve the question. How you will differentiate that patient is having mania or hypomania? First and important point is symptoms may be more or less same. This is recently asked question in NEET and a very difficult question that was. So yes, mania, hypomania. In mania, yes, there is socio-occupational dysfunction present. In hypomania, socio-occupational dysfunction is minimal or absent. Minimal or absent. Psychotic symptom present in mania, absent in hypomania. If psychotic symptom is there, delusion is there, hallucination is there, without second thought, diagnosis is mania. If socio-occupational dysfunction is there, without second thought, diagnosis is mania. If symptoms are same, I'm telling you symptoms are same, but if you find these things, you will mark the answer mania. Now, hospitalization is present. If hospitalization is there, the patient would not go to occupation, so definitely socio-occupational dysfunction would be there. The answer would be mania. In hypomania, hospitalization is not required. Symptoms are not so severe to hospitalize the patient. Duration of symptoms 7 days, 4 days. We remember this as main criteria, but actually this is not the main criteria. Main criteria are these. Other criteria, flight of idea, present in hypomania, prolaxity. All these points have been asked separate questions. Pseudo hallucination, this was recent NEET question, present in mania, absent in hypomania. They gave symptoms of these 3-4 symptoms they gave out of these, and they asked the patient is having mania or hypomania. Both options were there. Yes, but they gave pseudo hallucination, one more symptom, and on the basis of pseudo hallucination, we marked the answer mania. This is a really difficult question. Okay. Because we never discussed pseudo hallucination previous to this exam. Yes, trust me, it was new thing, and they asked, the difficulty level was really high. So you will remember, if a patient is having 7-day, 4-day, 2 days history of symptoms, but symptoms are so severe, I will not wait for the 7 days. I will make the diagnosis of mania even after 2-3 days. Means duration is not the criteria. Socio-occupational dysfunction is a more important point. So you solve this question, then you understand the importance of why I made this table. Yes, a 19-year-old man with no psychiatry history who has been experiencing 4 days. So they try to confuse 4 days. When you will see, you will think of hypomania. You will think of hypomania. Yes, for the time being, 4 days of irritable mood means irritable mania. Yes, or paranoid mania. Irritable mania is also called paranoid mania. Paranoid mania. Okay. Now, increased goal dietary activities brought to the hospital emergency department, subsequently hospitalized. I told you, if any question, if you find the word hospitalized without second thought, the answer would become mania. So answer is mania. And I told you, whenever mania is there, without second thought, the answer would be BPAD 1. So I will not see other things, but definitely symptoms: does not need sleep, decreased requirement of need, racing thought, he is grandiose, recently massive with credit card खर्च कर रहा है, watches खरीदता है. Most likely diagnosis is BPAD 1, bipolar 1 disorder. Understood? In this, duration is not important criteria. You will remember these 3 are more important than these 3. But if these 3 are not given, then you will mark the answer on the basis of these 3. Okay. Treatment of BPAD, acute mania, we treat by antipsychotic, or better, atypical antipsychotics. Or if one to choose among atypical antipsychotic, olanzapine. Yes, if single drug they ask, you will say antipsychotic is the best, atypical antipsychotic is the best. Then, yes, valproate or lithium. So this is really controversial thing, that we should use valproate or lithium. Which one is better? Yes, different guidelines says different thing, but we are concerned with our MCQs, how you will solve MCQs. If question is asked that where lithium is indicated, what you will do? You will search these symptoms where lithium is preferred over valproate. If family history of mania is there, family history of mania you found, yes, then you will prefer lithium. If euphoric mania, I told you mania may be euphoric mania or irritable mania. Yes, So if euphoric mania is there, patient is happy, then you will give lithium. If 3 or less than 3 episodes are there, you will give lithium. If no history of substance abuse, then you will use lithium. How you will remember? Family planning triangle. Yes, family planning triangle. You may see हम 3 हमारे, yes, हम 2 हमारा 1. Total कितने हो गए? 3. Yes, and all are happy. So happy means euphoric mania. Family triangle मतलब family history. 3 or less than 3, yes, episode. And if substance is not used, definitely family would be happy. Yes, and if opposite to that, then we will use valproate. Okay. So you will solve this question according to this. Rapid cycler. What is rapid cycler? If a patient came to me and in 1 year there are 4 or more than 4 episode. Yes, 4 or more than 4 episode in 1 year, then it is rapid cycler. R 4. In Hindi, sorry to be Hindi, R 4. Yes, 4 or more than 4 episode, we found that rapid cycler, the treatment of choice is valproate. Valproate. If a patient, mnemonic, if a patient is riding cycle very fast, I ask him to ride cycle on this wall. वॉल प्रोएट, तो वॉल पे चला पाएगा तेज, ही विल नॉट बी एबल. ठीक हो जाएगा, धीमे चलाएगा, ठीक ही तो करना है. यस, रैपिड साइक्लर ट्रीटमेंट इज वेलप्रोएट. नाउ लिथियम, एवरी टाइम यू कैन एक्सपेक्ट वन क्वेश्चन, इट इज हैविंग नैरो थेरेप्यूटिक इंडेक्स. यस, मींस prophylaxis 0.4 milliequivalent per liter to 0.8 milliequivalent per liter. Yes, treatment 0.8 milliequivalent per liter to 1.2 milliequivalent per liter. Yes, this range is changed in different textbook. I will simplify. Just remember 4 to 8, 8 to 12. And if more than 1.5 milliequivalent per liter, that is toxicity. Toxicity. It is rapidly and completely absorbed after oral administration. It is excreted by kidney. Okay, plasma steady state concentration is achieved after 4 to 5 half-life. Half-life. You have discussed or read in pharma. And we found that half-life of lithium is 1.3 days. So you can say that plasma steady state concentration is achieved after 5 to 7 days. Yes, this is important. In lithium, plasma steady state concentration is achieved after 5 to 7 days. What does it mean? Suppose a patient came to me. I want to start lithium. I start lithium and I will ask patient to come after 5 days. Or if it is in ward, we ask the resident to take the sample after 5 days, because after 5 days, plasma steady state concentration is achieved. So we take sample after, yes, take sample after 5 days. And when you will take the sample, suppose you prescribed 300 milligram morning, evening, night. Yes, suppose patient took the last dose at 8 p.m. You will come early 8 a.m. and will take the sample. Means exactly after 12 hours of last dose. How much? 12 hours of last dose. Yes, it is very difficult for residents when you have to take sample on Sunday morning after the party of Saturday night. Saturday night, आज तो party शुरू हुई है, तो you will not be able, so you will remember, yes, you have to wake up at 8 a.m. to take the sample before the morning dose. Yes, so now you will never forget. Yes, plasma steady state concentration achieved 5 to 7 days. So we take sample after 5 days and after 12 hours of last dose. And you know that this is excreted by kidney. So and having very narrow therapeutic index. So if you don't check kidney function test, this may lead to lithium toxicity. If kidney is not functioning, then lithium will not be excreted, will deposit in body, toxicity. So yes, excreted in kidney. So we always do kidney function test, pre-lithium workup. Pre-lithium workup. We also do thyroid function test because we know side effect of lithium, that is hypothyroidism. Yes, kidney पे affect डालेगी, it will affect kidney, diabetes insipidus, polyuria. Symptoms on questions are asked on symptoms. Yes, fine tremors. Suppose a patient is on lithium, came to you. What you will ask? You ask the patient to stress the hand. When patient will stress the hand, I will take a paper and will put on this, and you can see fine tremors by that. Don't forget to switch off the fan. Okay, so fine tremors you can check, but no need to worry, you will give beta blocker. But if a patient, you are sitting in OPD and patient is having coarse tremors, came with coarse tremors, you will think that it is a normal side effect. No, coarse tremors indicate toxicity. Immediately check reflex. There would be hyperreflexia. Hyperreflexia would be there. Ataxia may be there in this patient. Patient may go into coma, death. Yes, so coarse tremor indicate toxicity. Immediately send the sample for lithium level, and if lithium level is very high, do dialysis. Okay, treatment dialysis. How you will remember? Yes, lithium is handled by kidney, and the alternative kidney is dialysis. Yes, in last trimester of pregnancy, this recently asked controversial question. In last trimester of pregnancy, usually there is requirement of increased lithium dose. Yes, just before the delivery, we start tapering the lithium because we know immediately after, yes, during third trimester, that plasma volume increases. When plasma volume increases, this is controversial again, I am telling you. Yes, so if you give same dose, that will lead to decreased lithium level, and patient may present with symptoms of mania. But this question was asked, this was not a good question, because the answer should be, they must have given that if a patient in last trimester come to me, I will check serum lithium level. Depending on the serum lithium level, I will decide it should be increase or decrease. If last trimester, in initial period, definitely we will increase, but before delivery we decrease. They did not mention that it was the early part or immediately before delivery, because immediately after childbirth there will be blood loss, and if you are continuing the same dose, definitely this will lead to toxicity. So this was not a good question, but you will remember the concept. Yes, before delivery, yes, we start tapering the lithium. In the last trimester, we usually increase, but the best answer should be you will check the lithium level. Okay, dear. Mood stabilizer in pregnancy, mania. Yes, atypical antipsychotic. Bipolar depression or prophylaxis. If you want to give prophylaxis, then lamotrigine. Valproate cause neural tube defect. Lithium cause Epstein anomaly. Both are question. But the chance of neural tube defect is much more than Epstein anomaly. So question has been asked, if a pregnant patient came to you, which of the following drug is contraindicated, and they gave option both valproate and lithium. If one to choose, I will go with valproate. Yes, we say never ever give valproate in childbearing age group. Okay, because the incidence of neural tube defect is much more. Now, a question has been asked so many times on postpartum blues or baby blues, postpartum depression, postpartum psychosis. Symptoms, you will find that there is mild, sometimes in question you will find mild tearfulness, sadness, sleep disturbance, mood lability is there. These symptoms are there. Mild word, transient word. This is important, because many times when questions are asked, we solve the question. Yes, till now, whatever question are asked, I will give you the concept, don't worry. They have mentioned mild, transient, tearfulness is there, sadness is there, sleep disturbance is there, onset after 3 to 5 days, within 3 to 5 days, and last 4 days to weeks. Means थोड़े दिन में ठीक हो जाएगा. Duration is not the criteria, is the symptom, mild symptoms are there. Yes, then it is postpartum blues. Treatment is support to mother. Support to mother. But in postpartum depression, when you will say the patient is having postpartum depression, if depressive symptoms are given and you find the word suicidal tendency, anhedonia, guilt, severe symptoms are there, then you will mark the answer postpartum depression. So in the same question, if they give the word suicidal tendency, suicidal ideation, anhedonia is there, guilt is there, you will think. Okay. Yes, and onset is within 3 months of delivery. And in DSM-5, the name is depressive episode with peripartum onset. Okay, so duration is also different, but the criteria is symptom severity. Postpartum psychosis, psychotic symptom would be there, delusion may be there, hallucination may be there. Delusion, sometimes the content of delusion is that I have given birth to dead baby. ये बच्चा मेरा नहीं है, मैं तो dead baby को birth दिया था. Yes, this baby is demon. Okay, if these types of thought would be, delusion would be there, yes, false firm belief would be there, the patient may harm the baby. So what we do, we separate the baby from mother if we feel there is a risk. Okay, yes, this occur within 2-3 weeks of delivery. Okay, and the treatment is antipsychotic. Role of lithium is also there. In this, you will use antidepressant, definitely. Okay. So this is about postpartum depression, postpartum psychosis, postpartum blues. Now we will solve this question. Yes, and you will find the concept of schizoaffective disorder. Let me describe the first part. 23-year-old girl, yes, brought to psychiatry OPD by her mother because of a 5-month duration of symptom, 5-month history of feeling sad. One symptom is feeling sad. Mother says that during this period she has slept and eaten very little. Sleep, second symptom. Eating, yes, third symptom. Unable to focus at work, fourth symptom. She feel tired, decrease energy, five symptom. Five symptoms, more than 2 weeks. Diagnosis is depression. Diagnosis is depression till now. She has been hearing voices telling her that she is worthless. Depression plus hallucination. Hallucination is psychotic symptom. So you will say the diagnosis is depression with psychotic symptom till now. Why I am telling you like this? Because if question is asked up to this, then diagnosis is depression. Diagnosis is, I take this color, till up to this, diagnosis is depression. Yes, if question is extended till this, diagnosis would become depression with psychotic symptom or psychotic depression. Now, in the same question, yes, I leave this question. Okay, suppose this girl hearing voices for 7 months, which are, these voices are making fun of her. I am little bit modifying the language. Okay, she does not drink alcohol, use illicit drug, physical examination, neurological examination, no abnormality, MSc, speech is slow. Slow speech may present in many psychiatric disorder, not so diagnostic. Monotonous. She abruptly stopped talking in the middle of sentences. Yes, this is thought block. Thought block. Formal thought disorder. Does not finish them. Formal thought disorder. She is having delusion of persecution. Delusion is there. Occasionally directs her attention to ceiling as if she were listening, means hallucination. Delusion, hallucination, formal thought disorder, 3 symptom, more than 2 symptom for more than 6 months. Diagnosis is schizophrenia. Diagnosis is schizophrenia. So you can say in this patient for 5 months, diagnosis is depression. For 7 month, diagnosis is schizophrenia. For 5 months, schizophrenia 7 months. Okay, so in this question, both you can write like this. In this question, you find that depression and psychotic symptom are present during most of the duration of illness. Suppose this is 7 months, 5 months, 5 months depression and 7 month schizophrenia, means both affective disorder, depression is affective disorder, and schizophrenia symptom are present during most of illness. Yes, out of 7 months, 5 months is most of the illness. During most of the illness, patient is having both affective symptom and schizophrenic symptom. Schizophrenic symptom, schizo, affective symptom, affective, schizoaffective disorder. So in this option E, schizoaffective disorder. Got the point? So schizoaffective disorder, both affective disorder and schizophrenic symptoms present most of the duration. Affective symptoms may be depression, may be mania. So if it is depression, that it is, yes, means schizoaffective may be of two type. Yes, schizodepressive, schizomanic type. Got the point? In this question, if I say that if I remove this and I say this is the only question, yes, I remove this, this is the only question, these symptoms are present for 5 months. 5 months. You know, if less than 6 months, more than 1 month, but less than 6 months, that is schizophreniform disorder. We have discussed that if two or more than two symptoms are present from 1 month to 6 month, 1 month to 6 month, schizophreniform disorder. So in this question, 7 month duration is given, schizophrenia. If in question 5 month duration would be given, schizophreniform disorder. In this question, if less than 1 month duration would have been given, then answer would have been brief psychotic disorder. So you can easily understand the concept of duration, how questions are asked, and how you can change the answer on the basis of duration. In this question, if 5 month, the answer would become schizophreniform disorder. In the same question, if the duration is 20 days, then the answer would become brief psychotic disorder. Brief psychotic disorder. Okay. So I have explained each and every aspect of this question, how question can be framed. This question is particularly important for INICET. In FMGE, I have found that they are asking difficult questions, so you can't ignore. NEET, you can't ignore. So the purpose is that you should know those topics which has been previously asked and the difficulty level they have reached a little bit more. So we should consider all these things. According to that, our preparation would be ready.